I'm just going to give everyone a minute to connect to their audio. Connecting. Just waiting for everyone to connect to audio and we will get started. It looks like we're pretty good. Okay. All right. Well, hello, everyone, and welcome to today's virtual interactive panel discussion brought to you by the Healthcare Leaders of New York. My name is Sandra McGarry, and I'll be serving as your ACHE technical host for today. Before we do get started, I would like to go over a few items with you to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event, and we absolutely encourage you to use it. Please say hello, introduce yourselves, add your comments and questions as we go along. It just really helps to ensure a nice interactive discussion today. This session is worth 1.5 hours of ACHE virtual interactive education credit, and to earn this credit, you must be logged in for the entire 90 minutes of the event. All attendees who meet this requirement will have their 1.5 virtual interactive education credit applied within 2 weeks from today's event. I was just notified that some of you have already received those, so I'm going to ask them to clear it out and we will fix it after the event. We do encourage you to complete the evaluation for the event. I will be adding the link into the chat box, and I do ask that you please take a second to complete that. And to begin our session, I am going to hand it over to Carl Marie Memnon with the president of HLNY.
Good evening, everyone, and welcome to our session. My name is Carl Marie Memnon, and I'm the president of Healthcare Leaders of New York, the local American College of Healthcare Executive Chapter. HLNY represents over 1,900 members in the New York metropolitan area, providing access to networking, education, mentoring, and career development. Our mission is to advance healthcare leadership and management excellence through professional enrichment and continuing education of our members. In this virtual session, you will learn how significant capital expenditure decisions can make or break a healthcare organization and a career of executives tasked with such decisions. The healthcare construction boom continues throughout the United States for a variety of reasons, many of which impact both small community hospitals and large urban health systems alike. Changes in building codes and patient safety standards also drive the need for construction. And you will hear from our expert panelists this evening for more information about building in this environment. Next slide, please. Our moderator for this evening is Roger McLean. Roger is the Director of Design and Construction within the Facilities Management Department at Memorial Sloan Kettering Cancer Center. Roger has managed a project portfolio totaling $3 billion of healthcare construction within the New York City area. In his current role, Roger is responsible for the overall management of capital projects from the inception through occupancy for patient care. Roger and his team collaborates with MSK's corporate and clinical leadership to develop functional design and construction criteria based on the needs of MSK's patient population and operational needs. Roger has 20 years of experience in healthcare operations and healthcare construction management. Roger holds a Bachelor of Science in Marketing from the University of Hartford and Masters of Science in Construction Management from New York University. With that, I'll turn it over to Roger. Roger?
Thank you so much, and good evening to everyone, and I'm really excited for a great topic and some exciting and just extremely qualified and experienced panelists to take us through this discussion. Our topic today is about building the hospital of tomorrow, and whether that's rehab, renovate, or replace. These are some of those real serious decisions and hard questions that are asked by senior leadership within health organizations. And it's really the goal and the responsibility of colleagues like myself to really give those organizations the best insight as far as the strategic information that allows them to make those decisions. I'm going to just start off with introductions. So just, introducing our panelists. So I'll start off with John Flanagan.
Hi, good evening. My name is John Flanagan. I'm the Chief Operating Officer at Blythedale Children's Hospital. For those of you not familiar, Blythedale is an Article 28 children's specialty hospital in Valhalla, New York. We specialize in the post-acute care for medically complex children. In addition to the 94 Article 28 beds, we have 24 residential healthcare facility beds, so essentially a pediatric nursing home. And we also have an on-site public school district that supports our busy day hospital program. So Blythedale's invested over $150 million in our facility over the past 15 years. I look forward to sharing some of those experiences with you, as well as experiences I have from my 12 years at New York Presbyterian as a director of operations.
Thanks, John. So we'll turn it over to Melissa Kiefer.
Thank you, Roger. My name is Melissa Kiefer. I am the Vice President of Project Development, Planning, Design, and Construction for the Hospital for Special Surgery, which spans locations across New York, New Jersey, Connecticut, and Florida. HSS is the world's leading academic medical center focused on musculoskeletal health, and we've been ranked #1 in orthopedics for the last 15 years in a row by U.S. News and World Reports. I'm delighted to be here tonight to share one of my passions, the built environment, with another, the healthcare delivery community. So thank you, HLNY, for having us. At HSS, my role focuses on engagement across all levels of employees in the facilities planning process and how we enable our strong culture of excellence to translate into our physical footprint. Day to day, I oversee the life cycle of projects around that built environment. This includes working closely with operations, finance, technology teams to ensure that we're selecting the right projects, delivering them with the most effective set of institutional resources, and guiding how we think through the life cycle of our owned and leased properties as our strategic needs evolve. And one fun fact, one of my first jobs in this industry was actually working with Roger at Memorial Sloan Kettering. And we're both part of an institution called the Association for Medical Facilities Professionals, AMFP. So I'm very excited for the synergies of bringing built environment and healthcare operations together.
Thanks, Melissa. And last but not least, Christina Krell.
Good evening, everyone. My name is Christina Krell, and for the past 15 years, I've been a healthcare consultant and transition and activation specialist within the design industry. I started doing that work first as an employee with a large global architectural firm, healthcare architectural firm. And then around COVID time, I struck out on my own as an independent New York State women's owned business enterprise. I am a registered professional nurse, and I completed my graduate education in administration. And the first half of my career, I was in operations, and I was a chief nursing officer and a chief operating officer in the New York area. I'm a proud fellow in the American College of Healthcare Executives, as others are here. And I'm certified in project management and in evidence-based design. But perhaps my most important credential at this time is that I'm the current president of the Nursing Institute for Healthcare Design. NIHD is a North American not-for-profit membership organization committed to integrating clinical expertise into the planning and design of the built healthcare environments. So I'm very glad to be part of this panel and to be able to contribute a little bit of a different point of view, and certainly a clinical and operational point of view.
Thanks, Christina. So before we get started with this exciting panel and this discussion, we wanted to take a minute to launch some poll questions, just so we could get a chance to get to know a little bit more about the people that are here in the audience tonight. So the results are in. So it looks like heavy operations, a little bit of everyone tonight. So I think this will be a really good presentation and discussion. Sorry, I'm just getting this chat out of my. Sorry about that. So yeah, so I think we're gonna have a really great discussion, and let's get started with the questions. So first question to the panel: what are the key issues facing healthcare organizations when it comes to their physical facilities? Just to kick off that question, I mean, it's an ongoing challenge across all healthcare organizations. How much do you invest in existing facilities, code updates, different opportunities to where some buildings over time become a little bit obsolete from a design perspective and what they can actually accommodate? How much do you invest into capital construction? I mean, a lot of that depends on region. New York City is not only a tough place to build spatially, but also, from a financial and price point perspective. So where do you want to grow as an organization is really a tough question for leadership and C-suite within these healthcare organizations to answer. So I'll turn it over to you, John, to give us your perspective on that question.
Yeah, some of the issues I think about when we talk about what's affecting us as healthcare providers. Number one, aging infrastructure. When I was at New York Presbyterian, many of our buildings were built in the 1930s and 40s. And when you literally opened the walls and looked at a pipe, they would disintegrate to the point where we had to have plumbing on site anytime we went into a wall. So that's number one. Lack of real estate, just the lack of space, particularly in New York City. But even in the suburbs, here at Blythedale, we're surrounded by 3 roads and a row of houses. So even for us, we're a little bit landlocked. Cost of construction, of course, I'm sure we're all feeling that here, particularly post-COVID. A lot of the costs went up as supply chain got more difficult. Every time one of the ports is blocked or you have Teamsters on strike, fortunately that only lasted for a day, but that adds to the cost of construction. For example, we're looking at a generator replacement, and if I ordered that generator tomorrow, it wouldn't arrive for at least a year, probably a little bit more. And then the other issue facing healthcare costs, I think, is whether you're going to use union labor or not. And I know we all probably face that challenge. And then there's always the logistics. Where are you going to put people when you're doing this renovation? The decant question, and how do you plan for all of that? So those are, when I think about what's affecting us in terms of construction, those are some of the top issues that I think about.
Thanks, John. Melissa?
John, I think all of those resonate with me, particularly the decant one, as you tell folks they need to move temporarily and they'll get this beautiful new facility at the end, but that's always seeming too far away. But I do think, just to add on to what you said, it's really about, I think the biggest issue is taking all of those elements that you discussed and others like emerging technology and different ways of constructing things that can be faster and potentially cheaper. But it's how do we take that environment and make it into something that can be flexible into the future. Facilities are often one of the most costly items for a healthcare delivery institution. So how do we think about not only what we'll build, but what we'll continue to maintain? Should we grow? Should we move our facilities? Should we shift entirely to meet our patients where they are? And I think creating that flexibility and those off-ramps of decision-making is incredibly challenging. And we talk a lot about, in what I do at least, future-proofing, which is not really possible when so much time and so many dollars are required to build out these sites, that we really need to think about planning into the future and what could all the possibilities be so that we have plan A, B, C, D, E, and then are able to flex into those into the future.
Thanks, Melissa. I think the biggest challenge is that who has that crystal ball of knowing where healthcare is going as far as technological advances, as far as, different opportunities for at-home health versus within the facilities. So there's so many different questions, there's so many different opportunities that I could definitely appreciate how difficult those decisions are and the issues that we face going forward. I'll go over to the next question now. How do you prioritize capital resources when it comes to new construction or facility modernization versus other organizational needs? I'll turn that one over to you, Melissa, to start us off.
Sure. I feel like in my role, I live and breathe capital decision making. And at HSS, at least, we're constantly on this journey to broaden our definition of capital prioritization and how we look at it. We're in the precipice of really not thinking about facilities and construction as its own silo, but the lines between what is a facility and what is IT and what is equipment are all blurring and becoming less and less defined as technology continues to be more and more integrated into what we all do in our day-to-day lives and how we interact with different patients as well in our healthcare institutions. So I think too, the other piece is being transparent with your criteria. What are the guiding principles that are going to guide senior leadership and other leadership across your enterprise around how projects will be selected, how different things will be prioritized? And again, that flexibility piece. How do we create projects that we can explore to a point? Figure out if there's still the right move and what we think will be guiding our institutions into the future, and then pivoting if we need to invest in other capital priorities. So I think we have to be comfortable as healthcare institutions spending a little bit of money to answer those flexibility questions before we invest the end very big dollars in those capital investments.
Thanks, Melissa. John, do you want to opine on that question as well?
Yeah, completely agree with Melissa. I think for Blightdale, we have clinical IT and facilities at the same table talking about their needs and then prioritizing what little money we have to invest for the year. I think one thing I did when I joined Blightdale, there wasn't a good sense of where we were in terms of infrastructure. There were some concerns about the physical plant, but not really a good assessment. So I engaged with an outside vendor to come in and assess all of our infrastructure. I know New York Presbyterian does that on a regular basis as well, to really look at your chiller plant, your boiler plant, all of your HVAC, our elevators, to give us an outside assessment of how do you then prioritize based on the condition of all of those systems. And that's helped us as we look through the facilities portion of our capital program. What do we do? I think IT is becoming increasingly complex with the requirements, particularly around cybersecurity now. And what does that mean as you look at your Wi-Fi networks and how you're connecting your clinical equipment to your network? It's becoming much more expensive. But I think the other thing we talk about is, all right, how are we going to fund our capital program? And some of that, is through our investments, our philanthropy, and through our operations. But lately in New York, there's been this capital transformation grant program that we've also been looking at and trying to take advantage of. So 3 years ago for Transformation 3, we submitted a grant for our kitchen renovation, and we actually got something. Now, trying to get that money from the state is a whole nother webinar that we should do, because it's really a challenge to actually get that money once they've said you got the grant. But that helped us prioritize and do other things that we couldn't do. So I encourage everyone to look at the grant opportunities that are out there for capital. FEMA has a lot of grant opportunities for things around security or mitigation that are also out there. So those are some of the things we're doing to help us prioritize where we spend our money.
And Roger, if I could add one thing, because John inspired me. I think too, one of the hardest parts of prioritization of capital is the fact that we only look at things through a fiscal year lens. Yes, we plan year by year in advance, but I think how we look at planning these very long-term projects from not only what we're committing this year, but what we're committing for the next 5 years at a time, 10 years, whatever the outlook might be for your institution, is something that can be a challenge to navigate as well.
That's a really good point, Melissa. I mean, Master planning is something that is a word that's thrown around, but very difficult to accomplish. And there's so many different competing priorities. If you think about just the modernization of your, major modalities and the fleets that you have within your radiological practices and things like that. And then you look at what about clinical growth and what about, maybe there might be some research space. So how do we grow talent and, bring in the right individuals as far as having the right research facilities, having the right education opportunities, but at the same time, think about that clinical engine that really keeps the business going. So no small task in trying to think about that prioritization and where we want to put dollars in the right place. So thank you both on that. So I'll go over to our third question, which is who are the key stakeholders, both internal and external? Who needs to weigh in on design and construction decisions, and whose approval is most important and why? So Christina, we want to start with you and your perspective on that one.
So, there are, some foundational elements of any good project, including a building project. And we spoke about having guiding principles. We spoke about having a budget and managing our capital. And understanding our stakeholders and who they are is important as well. Any well-run project not only identifies the stakeholders, but they also give consideration to how and when they get involved. In a building project, it's in some ways, it's everybody. It is the community, it's the staff, it's in the investors, it's the benefactors, it's the contractors, the designer, it's board members. It is literally everybody. The list is one thing, but it's just as important to take the time to understand their stake in the game, because certain people, certain groups of people have an opportunity to either help or hinder the success of the project. And understanding that allows for the project to be more successful. Who are decision makers versus who are those people who just have a need to know? As project sponsors or the project steering committee, everybody, creates user groups, and there's dozens and dozens of people, sometimes without consideration of who they actually are and their level of power, or what groups that they represent. And it's not just during, let's say, design development when we're assembling these user groups. It is literally from the beginning, from master planning, all the way through post-occupancy evaluation. It is necessary to have the proper people on the proper place during the proper phase. Now, with my involvement certainly at NIHD, but being on the owner side at one point during my career, and my understanding of the importance of having frontline users involved in this process, and they are stakeholders, big and important stakeholders, and it's important that their voice is heard. And I know that's difficult. Our staff are busy. They have competing demands. They're in short supplies, and it's not always easy to get doctors and nurses involved in building projects. But it would be short-sighted to not do that. So, of course, my point of view is you have to have nurses are really important. Nurses and clinicians and therapists and doctors are paramount to stakeholders, but there are many others.
Thanks, Christina. Melissa, you want to chime in?
Yeah, I fully agree with Christina on all points there. I think too, the other thing thing I was thinking about as you talked about who's empowered to make decisions and what level of understanding they have. Interest is also something that I think is key when you're selecting stakeholders, to make sure they're passionate about the project and will take on that responsibility of being an end user and go back to their department, their team, their people that they work with, and collect feedback and bring that back down to the design team when they're at the next meeting. The other group that I think about a lot is in the feasibility stage, the regulatory piece. I think the community stakeholders that we all play a big part in to deliver not only bringing our services as healthcare providers to those communities, but how else are our projects disrupting their lives? How can we contribute a lot in New York City? We're asked to help build parks. We're asked to help contribute some of our fundraising dollars to other city initiatives. And so I think those pieces and working closely with the municipal agencies, whether it be DOB in the city or city planning or out in the suburbs like you are, John, the different townships that have their own priorities and needs and development challenges as people keep land grabbing and things keep getting built around us in New York City.
Thanks, Melissa.
I'll jump in and add to what Melissa said. So I think absolutely you have to think about the Department of Health and your local towns. And I think we'll talk about that a little bit when we further into the program. But, the Department of Health is, they have to bless, we all have to do the certificate of need process. And if you're doing, a renovation that might qualify as construction notice, you can pretty much skate by. But if you need anything that's limited review or below or above, you need to gauge the state on their interest in your project, whether that's adding or subtracting beds or services. They're a critical stakeholder early on. Most of you probably know by now that they've instituted the health equity impact analysis. And again, we could talk a little bit more about that under the community portion of the program we're going to get to in a little bit, but that's also become a way for the state to gauge the community and other stakeholders in your project. And I can talk about that later. But the other piece that Christina talked about that I wanted to highlight just for myself is a learning opportunity and moving sort of from the director level to the executive level is that the Board of Trustees is a huge piece of this that I never really appreciated when sort of I got the project in hand and said, okay, you're going to renovate this inpatient unit or you're going to renovate this lab. I kind of did it and I was the operations person to do it. But at the executive level, you really have to engage your Board of Trustees. The project starts with them in a way. You have to sell them on your concept. You're going to have to sell them on the purpose of the project. They have to buy into it, and then they have to agree to the budget for that project. And so they're so important. Even if they're not the most hands-on board, this is one area where I think most boards really take responsibility when it's approving millions of dollars for a capital project, as well as knowing that we're going to get the state involved, knowing that we have to get the community involved. It's important that they're on board. And so that was kind of a learning opportunity for me over the last few years in dealing with the board. And then the other group that I think we have to talk about is our donors. So many of us rely on donors to fund some of these capital projects. And depending on who the donor is, they could either be completely hands-off once they write their check, or they can be very involved. And so I worked on a project at New York Presbyterian where these donors, for a great project, they wanted to literally be involved in paint colors and flooring options and the decor of the organization. And that was a different type of challenge than we typically had when the donors weren't involved. So something you really need to think about as well.
Yeah, just let me conclude this topic by saying that what John and Melissa talked about has to do with not just identifying those stakeholders, but really analyzing their involvement and their level of influence. Sometimes the person who you think runs the whole show is not, and what may be perceived as a minor player can literally bring a project to a screeching halt. And when you really study that in advance and have that knowledge, when the executive team and the project sponsor has that knowledge, the project can be much better run.
Thanks, Christina. Great perspective from all of our panelists here. It sounds like all great development projects are anchored in good governance. And the way that you set up your subject matter experts, you set up your decision makers, you set up your financial partners, you set up your communications partners, really allows for projects to be successful. And it really gives people roles and responsibilities. And I think that that really is key to a really great development project. So thanks, panelists. So I'll move on to the next question, which is, to what degree do environmental factors impact your decisions and design choices? John, you want to take that one?
Not really, but yeah, I mean, lots of different environmental factors impact our decisions and design choices. When I was at New York Presbyterian, we participated in a program called Planetree, and I know there are people on the call that are familiar with Planetree, which is a model of patient-centered care that focuses on the healing environments. And so that was some of my initial education in how does the environment affect the healing process for our patients. So when you look at lighting, you look at the design of the facility from the perspective of the patient. And so having focus groups with patients and getting patients involved in the design of the facility during schematic and design development, very important, but also thinking about artwork and the power of artwork, the impact of the colors you choose, and really taking advantage of the campus where you're at. So if you're in a city environment, that's going to affect some of your design choices, right? Noise, traffic, lighting, things like that. If you're in the suburban environment, you might have more option to take advantage of the outdoor environments. Maybe noise is not your issue, but it might be managing the landscape, for example. So those are some of my initial thoughts about that.
Thanks, John. So just jump into our next question. How can you design facilities that improve the patient experience without appearing wasteful? Christina, you want to give us your point of view on that?
Yes, I do have an opinion on that. I think, first of all, any design element that improves the patient experience probably isn't wasteful. That said, I certainly understand that resources are not limitless, and sometimes the organization has to choose between needs and wants, and the budget really only goes so far. Over the years, this concept of patient experience and patient satisfaction, at least on the inpatient side, has really risen to the top. So we can think about things like a private patient room or having views to the outer doors, which in fact now aren't really amenities, they're regulatory requirements. But you can have upscale finishes or nice decor, or making certain that the patient room now is divided into zones, that the family zone is just as nice as the patient zone, as the staff zone. There was a time when this patient experience concept was huge. I think we remember when we used to send staff to, Ritz-Carlton training, or when everybody was sort of hot to trot on doing things the Disney way. And even the concept of on-stage, off-stage design, which is still popular to a certain extent, came from them. But I'll share this story on this topic. And it was about 10 years ago, I was on my first project that was an acute rehab hospital, my first rehab hospital project. And the only requirements that the patients had, and they were really outspoken about this, was that they wanted the staff to have their needs met. Because when the staff could do their job, then they got better. Then they were able to improve their functionality. That it was the therapists and the nurses that took care of them. So so that was all the patients really wanted. And I think that idea of let's take care of the staff so the staff can take care of the patients has really resonated of late, certainly, I believe, since the pandemic. And so we see that now in some attention being paid to having decent break rooms that can really meet a variety of staff requirements, whether it be a place to have their lunch or a place to take a phone call or, you know, place to charge their phone, or respite rooms, or even decent locker rooms, or you'll ask the staff, number one is parking. You know, do they, first of all, do they have it? And the second thing is, how close is it? And and how far away is it? And if I have to walk from parking to my work unit, is it indoors? Is it covered? So I think there are a variety of, if you will, amenities for patients, but I think there is this push as well to have amenities for staff, so that the staff can take care of the patients, then the patients can have a good experience. And I think there's just as many examples in the outpatient setting. So I think Melissa's going to talk about that.
Sure. Yeah. And I love that you brought staff experience into this, Christina, because it is so important and something we think about a lot. We're investing in our first physical footprint for a wellness center for all of our employees. And even trying to give staff some level of choice in how we build these things for them. So we do things like right now we're trying to help them help us pick furniture for them and what's the most comfortable way to rest between what they need to do to care for our patients. But on the ambulatory side, in particular, I think we think a lot at HSS as a musculoskeletal hospital. So we always want to think about movement, about preventing injury, and how do we prevent trips, and everything down to every finish that we will use. We work closely with our infection prevention teams and our EVS teams to make sure that everything that we select to go into our facilities is going to support that patient experience, not only from how the facility necessarily makes them feel, but how it supports their overall health mission. And I actually in another life, I was in the hospitality industry. And so I think about service a lot. And so how do we train our staff to greet patients when they're in the elevator, say, oh, can I help you? Because you know that the elevator is going to open both ways because it's a hospital that was built in the 50s over decades of reconstruction. Oh, you're going to radiology. Well, you need to take this left to this right, and taking that first step. But I don't think, again, as you said, anything is necessarily wasteful. It's about being thoughtful in how we spread the limited resources that every institution is going to have, whether it be staff time and training or capital dollars in purchasing a marble wall versus a porcelain tile wall.
Right. You know, you brought up a good example. You know, in surveying patients, what the feedback we get is that it's not easy to navigate a healthcare building. It's, you know, wayfinding is most difficult. We send patients hither and yon, you know, doing multiple things over and over and over again. And our ability to streamline that through design solutions, I believe, can be one of the most beneficial future solutions to improving the patient experience. And of course, that involves a lot of technology, whether it be, wayfinding on your own cell phone, or registering at a kiosk, or sending patients not first to registration, but let's say right to the outpatient surgery department. They get to pass go. You would think after all these years, we would have figured it out. But you talk to a patient, and I'm of an age now that I'm a patient more often than I wish I was. And it's very difficult. It's very difficult to navigate these large, spread out, complicated, added on to campuses.
When I think about this question, I think about my go-to, which is the add alternate. So as we're designing projects, and something would be great. So first of all, I agree that if it's about patient experience, it's not wasteful, but we do have to prioritize our resources. And so I love going to the add alternate if I don't want to completely nix something that I think would be really cool for our patients, but we think it might be too pricey. Put it in the project as an add alternate. Let's price it out and see, because sometimes we get surprised, or sometimes we save money somewhere else, and then we're able to have that added to the project, and it's not a complete change order because I had it in the base as an add alternate. But I think the other thing that's helped, around patient experience and some of the things that we know are nice for patients, good furniture, good finishes, all of that, is having standards for your organization, which then allow you to, economize, with your purchasing contract. So, if you have a standard floor that you use that everyone likes, that's durable, and also nice to look at. If you have furniture that's you use in all of your projects, that's durable and nice to look at, with 3 or 4 options for different upholstery, then you can economize with your contracts, whether that's with your furniture vendor or your or pricing organizations like Premier. You can take advantage of that if you consolidate into sort of a handful of options, and then it looks like you actually have a plan for your organization versus each project doing sort of an independent design every time you go to the table.
And I think just to add one more thing to that, Roger, I'm sorry, design's the most fun part of, and thinking about patient experience is the most fun part of a healthcare project. But even into those standards, there's ways to make that wayfinding patient experience, like pick different paint colors to go to specific modalities so that there's a natural, you don't even have to explain it, there's a natural way that people react to their environment. And one thing that I always like to think of, I don't know if they still do this, but I remember reading an article that Starbucks would make the area above their cashier much brighter so that you would go right into there, and then make the rest of the area a little bit dimmer so that it was more relaxing. And I always think about that in patient care, because you're going to pay for lights regardless. The level of light these days can be adjusted. Do you light up really bright where that patient is supposed to journey through, and then create those back of house areas that you don't necessarily want to go in them, but maybe you don't want to add doors for whatever reason? Have a dimmer space where staff can take a moment to downregulate and like take a breath before they go and serve that next patient. So I think there's ways to integrate patient experience into the things you're going to buy anyway. But I love the practical add alternate call out, John.
Yeah.
And you know what,
Yeah.
Melissa, that just reinforces your comment that a project needs to start with guiding principles. And it sounds like one of John's guiding principles is we have this system. It's we call it the add alternate system. And if somebody's got a good idea, we're not going to lose it. We're going to get it on a list, and it might happen. That's a lot of projects don't have. That's not part of it. They don't have that. So that's a great idea, and something to be made known right from the beginning.
Melissa, you talked about design being so fun, and it just made me think, because I think it's a lot of fun. I love doing it. So I love doing construction projects as an operations person. But that's not what my training is. Like when I went to grad school for my MPA, we didn't have architecture classes, we didn't have design classes, we didn't have construction classes. So I will just put a shout out for all of those of you who are still in your programs or early careerists. Absolutely take advantage of any classes you have on design and construction, because it will come in handy if you're in the operations world in healthcare. Like, you'll come across a construction project more often than you would think, and it will be helpful background to have.
Well, as long as you brought it up, I let me put in a pitch for not only my own organization, which is the Nursing Institute for Healthcare Design, but any design related organization. And that's not to say that you need to, turn into an architect, but during the period of time when you're in a building mode and you're assigned as a user or a member of the project, go to these conferences that happen annually. Before the conference started, we were just talking about some of them. Join, if allow one or two of your nurses who are very enthusiastic to be users, have them join NIHD for a year or two so that they have access to those resources and they become knowledgeable and informed project members and users. So I'm glad you allowed me to say that, John.
Great perspective from everyone. I think that what it comes down to is, if you really want to maximize the patient and the staff experience, it's really this merger between the design criteria and the operational criteria that really, everybody here has been to a 5-star restaurant that has a 1 Yelp review, because you got to merge those things together. Beautiful space with beautiful operations really makes those two things come together. So I definitely agree with this panel. Just as an example, within MSK's framework, back about a decade ago, we really looked at trying to put a lot more emphasis on the staff experience, because we were just dealing with the, nursing shortages, which is continuing to today. The burnout that really happens in a healthcare environment when you're dealing with just so many different stressful situations throughout the day. And we took a couple of our clinical leaders and hospital administrators over to Google's office, and we toured it to really show, an example of how they've really embodied that sort of staff experience. And really, from a food perspective, I mean, we went into their food hall. It is like, I can't even explain the amount of, options and choice, and just it was insane. So, we really looked at their model. We couldn't replicate it because obviously we're a totally different type of organization, but just a lot of the core cultural aspects of how they embodied the importance of staff experience, staff engagement, was a lot that we took into some of our more recent projects that we developed. So moving on to our next question, which is, where do patient safety concerns enter your plans? And we'll start with you on that, Christina.
Well, it enters the plan from day one, to be sure. Patient safety, and for that matter, staff safety, needs to be considered really right from the very beginning. And, this is another good reason to involve the frontline staff and others that are in the know about that sooner rather than later. I always have the infection control practitioner as a, if you will, a permanent project team member, as well as your, chief security officer and your QA people. They bring that expertise to the deliberations all through the design phases, whether it be the beginning or the end. I don't know how many in our audience are aware of the Center for Health Design, but again, a member organization of people who are bringing together the healthcare industry and the healthcare design industry, and they have a safety risk assessment tool. I have used this tool on every single one of my projects. It's, I believe it's a resource that's freely available. And even if you're not involved in a design project, it is definitely worth referencing and looking up. From a design point of view, you know, when I say we, I mean nurses, we are always considered with concerned about patients' falls. I mean, it is one of the biggest risks we have, certainly in the hospital. So we look at things like, you know, lighting and the distance of the bed to the bathroom, and the design, the actual design of the bathroom. I can tell you that for most projects that are under design now, we have cameras installed in every patient room. And I know that at times there are, you know, it's like, really? But the fact of the matter is that it's there for telehealth, but it is also there for what we call virtual sitting. That is, instead of a nurse's aide sitting next to the patient's bed 24/7 when they are a fall risk. We have cameras available for staff safety. There are cameras all over behavioral health units and obstetrical units and pediatric units. Staff have panic buttons, whether they're, you know, fixed at the station or they're remote buttons that they carry on them. You know, a lot of thought is given to how many entrances and egresses now when it's a whole building or a patient tower replacement. And depending on the hospital's location, the city where they are, they're installing walk-through medical detectors. You know, the first time I heard that, it was like, oh, really? That's terrible. And then I think to myself, well, no, it's not that terrible. I go through a medical detector every museum I visit in New York City. So from the security officer's point of view, why not do that, certainly in a hospital? So numerous other safety interventions. Behavioral health furniture has exploded in their capabilities of how they can create a safe environment for a patient who could possibly harm themselves or others. It is a very hot topic, if you will, in current design projects.
And I would
Thanks.
just add that as part, if you're doing a CON for this project, you have to submit a safety plan to the state, and that covers not just the project itself, but also how are you going to keep your existing patients who are in the adjacencies safe, for whether that's how are you going to deal with the noise that's generated from your projects, how are you going to deal with the infection control. We all have to do that ICRA assessments for the projects. So you got to think beyond just the actual project and who else are you going to be affecting. When I was at New York Presbyterian, we built an entire floor over our behavioral health units. So you would imagine behavioral health, you want those patients not to be agitated by noise. They need to get rest. And so we had to put a whole plan in place on how we were going to manage that during the construction. Particularly, it's always in the demo phase and getting the steel up. The loudest parts of the project can be really challenging. So you have to consider that as well.
Melissa, do you want to chime in on this one as well?
I think they've had a lot of great things to say about safety. I think we also think about it from what happens once the site opens as well. How are you going to operationalize if there's any incident that needs to happen? And we've thought a lot about how do you equip your buildings from a technology perspective to be able to support your security, your emergency management teams, to be able to react to safety concerns. And how do you use different things like AI to screen what's going to happen in your environment, to predict things like leaks on the floor so that you can dispatch your EVS team. I mean, this is all very pie in the sky stuff that's starting to become very real in the tech environment that we're looking at.
Thanks, Melissa. So we're gonna jump into another poll question.
I'm very interested in the outcome of this one. What resonated most with you all?
Shocker.
Cost and space.
Cost and space. Yeah, I think speak for every, person within our industry that those are the top two challenges across the board for sure. Why don't we just launch the third poll question, and then we'll go into our final question for the panelists, and then we'll do Q&A after that.
I think it might have only been two, Roger.
Oh, did we just have two? My
I think
apologies.
so. No worries.
So I'll get right back into the questions then. And this is our final question, and this is for you, Melissa. How is the
Not a
shift?
pressure.
How is the shift to digital healthcare and more healthcare outside the hospital overall changing your approaches?
I think it's changing every conversation I'm having, whether it's from how we're procuring services to get our partners on board, with our materials management supply chain teams that we work with. It's how we manage projects and make sure that we can leverage all of this robust, very juicy data around how projects are happening real time and turn those into dashboards so that leadership understands the health of their project, that board members, that donors who have invested a lot of their time in there understand how things are going. But then when you get into the design part, the part that I think all of us enjoyed roundtabling about the most tonight, it's really thinking through what's going to be the most simple. The most frustrating thing that can happen to an end user is going into a conference room and not being able to get the screen to connect to your laptop, to pick up the phone and make everything work. Sometimes we often with technology over design. And how do you find that balance to really focus as much on the end user, the patient, the employee, whoever that may be, who's going to use the space? And I think our technology partners are ready and waiting with us to do that. And we really need to be thoughtful and bring our technology counterparts in our institutions into the design phase. We've really started to do that even in the first of three phases as you do a design project is called schematic design. And that's where you really think about what rooms will go where. And we're with them because we want to make sure that the infrastructure they need to make all of these things work is in the right place. And I use the conference room example because I think everyone has probably experienced that and seen the little dongle with all the different ways to plug in. Are there ways that the technology industry is going to help us get there so that we don't have so many options? And things like universal chargers, I think, will help everyone as we move forward. And how do we connect and force the tech corporations as a whole world, global wide, to make sure that everything everyone can use is flexible across whatever ecosystem you're living in.
Thanks, Melissa. So I think it's a critical piece to just not only just digital, but even the whole virtual aspect of it, lighting, ease of use,
Mhm.
all those different things are really critical into making that work successfully. So we have a few questions here that I'm going to pose to the panelists. First question is, what advice or guidance can you give for someone trying to get into healthcare operations / design? Open to anyone that wants to take that one.
Oh, I mean, I can start, there are probably, I would guess 1,000 people who do what I do. And we often have people call us up and say, how did you get into this business? And it's usually an operations person who had the joy and excitement of being part of a building project at their own facility. There are formal education programs and certificate programs that you can get trained to do that. I think, all of our panelists kind of learned with on-the-job training. As a member of the project leadership team on those projects that I'm engaged with, we make it a big point to educate our users. Otherwise, they can't be valuable contributors. Just like I know how to be a nurse, there was a time when I had no idea how to read a floor plan or understand design acronyms, or there are architectural firms and consulting firms and management firms that hire healthcare operational design specialists. And that's, there are job boards for that. You can look around for that.
I think of a story when I was an undergraduate student studying how to run a hotel, a hospital. And I remember they require you to take a class on how to run the building itself. And I was very fascinated by the HVAC, which is pretty much the air conditioning system for the building. And totally fell in love with that section of the class, went off, worked for a hospital, decided I wanted to learn from the ground up, just like I did in hotels. I was a waitress, a sous chef, all of those different things. And so I was a front office staff member in a position of practice at Memorial Sloan Kettering. And I saw a job posting, just as you said, Christina, with the design and construction department, and a light bulb went off, and I remembered how much apparently I loved air conditioning systems. And I talked to them, and I built a career on just the exposure, sitting next to peers like Roger and other people who were teaching me as I was helping them. So I think curiosity, asking questions, and not being afraid to help stuff envelopes when a project manager needs to get notices out to a neighbor that a construction project is going to start. I think those sorts of things are always helpful to gain exposure to those different things.
Absolutely. And I would also, if you're still in grad school, especially if you're a first year, take advantage of the summer internships between your first and second year. There's lots of them out there. A lot of great, hospitals in New York City in particular have great summer internships to take advantage of. Some have fellowships, although they're fewer and farther between. But also I would say just ask. So I was doing a project where we were renovating nursing units, and I had on one unit a really engaged nurse. And she's like, I really love this stuff. It's really interesting. And I was like, great, because I have another unit where they're not so interested. So you will be my nursing representative on this project moving forward. And of course, I got permission from her director and the CNO, but she asked and expressed interest, and she was engaged. So I took advantage of that. So if you're interested, don't be afraid to ask your facilities design people or your operations liaisons to the projects to participate, because more often than not, we'll probably say, sure, we want the engagement.
And I think express that interest early. Often these projects start in a smaller strategic team who are really thinking about meeting specific needs, and then they explode quite out of nowhere sometimes. And depending on what role you're in the hospital, make sure people know you're interested in it, so that those experiences, when they do pop up, you're on their radar.
So before we go to our last Q&A question, wanted to just circle back to a very important topic. And John, wanted to give you a chance to give a perspective on this. Are there bond rating or community perception implications when it comes to new hospital improvements?
Yeah, so I'm not a finance guy, so I'm not going to talk about the bond ratings, but there are absolutely community perception problems to all hospital improvements. I know everyone on this panel can talk about them, but you need to engage your communities early on for major projects. And so, you need to do it just from a regulatory perspective. You're going to need to get, if you're in the city, you're going to need to get community board approval, then you're going to need to go get your permits. Up here in Westchester, you generally have to go to your town boards and work through the planning board, the zoning boards, the architectural review board, and the communities here. And I know in the city, the community boards are often very engaged. Roger, I know you can talk about that, and Melissa. And even here in Westchester, in the little town of Mount Pleasant, maybe not so little, but they might love your mission, but there's a lot of not in my backyard. And so back in 2009, when Blythedale wanted to build its new hospital, it took a little longer than we initially wanted to, because there was a handful, and it doesn't take many, there was a handful of community members, neighbors, who were worried about the expansion. They didn't want the additional traffic. They didn't want the additional, we have a school. They didn't want to see school buses. And quite honestly, there were people in the community who just felt like they didn't want a hospital in their backyard. Mind you, Blythedale was here first. There were no neighbors when Blythedale opened up. The community grew around Blythedale. They bought their houses when Blythedale existed. They knew they were buying next to a hospital. Even still, that will not stop your neighbors from expressing their concerns and their issues. So how do you mitigate that as you're moving forward with a project? Communication, communication, communication. We're working on a project that I don't even know if it will get approved at this point because of some of those cost issues we've discussed earlier. But our directive from the town, who we met with informally, was you better talk to your neighbors now. And so for a project that's not even on the agenda for the town yet officially, we talked 6 months ago with our neighbors to say, hey, this is what we're thinking. What are your thoughts? And as expected, the concerns were around traffic. The other thing is, when you are doing projects, let them know ahead of time. If I have a crane coming to lift something onto the roof, there's a particular neighbor who holds himself like the community board leader. I call him and I say, hey, we're going to have this going on. If you notice activity in the morning, we won't start before 8 a.m. because the town has rules around noise. And I let them know ahead of time. And then you may need to mitigate some of these issues, with the neighbors. I've already had to plant some tall trees to block off some of our parking issues with our neighbors. And, so that was worth it to me. If that was going to make them happy, I was happy to add the plants. Now, the state has added the health equity impact analysis. So those of you who've had to do a limited review or a full CON know about this now. It's been around for maybe just a year, so they're still modifying the process. But as part of that, you have to engage with an external vendor. You can't do it yourself. You can't have the person who does your CON do it. It has to be a third party who comes in and essentially evaluates your proposal to its effects on the community. And so that's where the community, and it's a wide range of people that they reach out to. They wanted to talk to, because I'm doing one right now. So they want to talk to your staff. They want to talk to leadership as well as direct care staff. They want to talk to patients, family members. They want to talk to any of your current community partners that you work with, just to get a sense of what is your reputation in the community. They're talking to the Department of Health, the local county Department of Health. They're talking to the local business associations. And they're evaluating whether, now our plan is to build beds and add services to this population that doesn't typically get the greatest care, medically complex children. And so from a mission standpoint, it's great. But if they go and talk to some of the neighbors, they're going to say, we're worried about traffic. So the health equity impact analysis is a new interesting aspect of the CON that you really have to think about. Who's your community? How do you prep them for the project so that when this third-party consultant goes and talks to them, they're going to talk positively about the work you do and the project that you're proposing.
And I know, John, none of us wanted to really dive into bond ratings, but I will chime in because I think it's important for the audience to be aware. All of these projects either take capital dollars that the institution already has, donor funding, and the other way to do it is also through lending dollars. And that's where your bond rating really comes in, and the amount of money that you're able to borrow against the future projects that you're going to build. So I do think if that's something that everyone should keep in mind as projects are being planned, because there are opportunities if big projects or a big plot of land becomes an opportunity to purchase or develop or something like that. That's where your bond rating is really gonna to play a part. And since the question was asked, I just wanted to have a minor opinion on it as a non-finance expert.
And just to add to that, so in addition to the bond rating, so I mentioned earlier, we had gotten one of the Transformation 3 grants. A part of that whole contracting process, which also involves HUD, who's like the lending agent for the state, is they do this reputational review of every vendor that you plan on submitting reimbursement for. So I'm having to go through, so the construction company and the furniture vendor and all these people where I'm going to submit invoices from them to the state to pay me back, even though I've already paid the vendors directly. They're looking at the internet and they're saying, okay, this vendor, Johnson Construction, they have 3 lawsuits outstanding. Can you explain those lawsuits? So now there's a back and forth, because before the state can write you a check, they have this vendor credentialing process, essentially, that, I never thought about, I would have to worry about my vendor's reputation in the sense of what's happened with them on other projects. I know what their reputation is on my project, but now to get that state money, I'm having to do a deeper dive with our partners. So just keep that in mind as well when you're choosing your contractors and vendors.
Thanks, John. Very important point, that community perception, especially in major developments. I mean, there's an education piece that's associated with this as well. People are concerned, but right now, one of the major developments that MSK is working on has, school to the west of the development site, where identified that there's hazardous material within these 2 buildings that we need to demolish. And people are nervous. People are afraid. They're worried about their well-being. They're worried about their children's well-being. And it's really about educating them around what are the measures that you take as far as the mitigation. How are you going to be a steward of the neighborhood and make sure that all of these different construction phases are done within accordance to the needs of the surrounding neighborhood? So it's one of the most critical things. I mean, we just literally got through our land use process maybe about 2-3 weeks ago, and that was a 24-month process of constant communication with the different community boards, talking to elected officials and really getting them to understand exactly what it is that we were looking to accomplish. So it's a critical piece to major developments and minor developments. Like John said, if you're gonna close down a street to, rig in some type of equipment, communication is key to really allowing these types of opportunities to happen successfully. So we have one more question from our Q&A. So here's the question. Are you taking climate change measures into account when reconstructing/building? So any one of our panelists who want to take that question.
Sure, or go ahead, John.
No. I was going to say, I want to hear from our friends who are along the river. about.
Yeah, no. Well, absolutely. I think we are. I think one, the environment from a regulatory perspective is there. In New York City, at least, there are local laws that are requiring us to think about our energy management. But then I think we're also Department of Buildings is requiring, solar panels or green roofs when you're building new things. And how do you contribute not only to the energy management piece, but what are we going to do with all of the excess trash that we create? And how are we going to take that offsite in a sustainable way? We are constantly thinking about where can we put bottle fillers so our employees can use, the same bottle, which they want to do. And we can do that rather than having to awkwardly fill in a water fountain. So we are thinking not only on that granular level of things like those bottle fillers, but we're also thinking about and a bigger level, how can we contribute to the overall city and community mission around energy management, which whether or not the grid can take all of that in the future is a big concern. But happy to go along that journey and happy to be a participant and voice our concerns, particularly because we are in critical buildings that need power 100% of the time. Yes, HSS, of course, but particularly for hospitals like yours, John, and yours, Roger, that run and have critical care units that cannot shut down and have to have those generators and can't rely just on that to keep moving.
Yeah, I mean, I think, the aspiration of net zero is tough for healthcare organizations, just based on the need of power and cooling and air changes and all the different regulations that really allow for our clinical environments to be safe. So it's that, taking the extra step around some of the things that Melissa mentioned around sustainability from a capital construction standpoint, from an operational standpoint, and really getting the buy-in organizationally to really want to reduce carbon footprint in any way possible, throughout this life cycle of the project. Even the construction phase is something that we've identified opportunities to be sustainable as we're demolishing a building, be sustainable as we're building a new building. So, and it has to be, a top-down approach, and really having those champions in the leadership group that won't stand for anything but that way of business. So I think across the board, especially in the healthcare environment, like I said before, net zero is a goal and it's an aspiration, but it's very difficult within the needs of these facilities.
And I was going to say, relying on our research partners, the new technologies that are coming out there, different higher education and research institutions that are leading the charge on creating different products and systems that are going to feed into what we use today, whether it be the type of fabric on a chair, the type of wipe we're going to use when we clean off an exam room, or the crane that we're going to pull in to bring up whatever materials we need to that high place for our buildings.
Thanks, Melissa. So with no other questions within the Q&A, I think we're going to conclude tonight's discussion. We want to thank everyone who joined this evening. Oh, I'm sorry. I'm turning it over to Darren. My apologies.
No problem. Well, thank you so much, John, Melissa, Roger, and Christina, for such an incredible conversation about building, rebuilding facilities and spaces here in the future. Really looking at building flexible, integrated, future thinking spaces focused on our people, looking at guiding principles and having standards across our organizations as we plan out these new spaces, and really keeping all of our stakeholders in mind in terms of the patient staff experiences. Thank you again to the incredible panel for this conversation. Next slide. And segueing from this conversation of spaces and buildings and thinking about technology, please join us on October 17th at our digital health and healthcare delivery systems virtual event, along with some of our other upcoming events, Equity of Care, our in-person event at Hofstra on October 30th, a community service walk on November 10th, along with another virtual event that we're hosting on November 12th, focused on post-acute care settings. An in-person event again at St. John's University, our annual Frank Camerano Memorial Dinner and Lecture. And then, of course, join us December 3rd to introduce our new executive board, along with celebrating with our fellowship at our holiday party at Terrace at the Park. Next slide. And as always, thank you to our incredible sponsors. We couldn't do what we do to add value for our membership, for our region, without the support of each and every one of you. Thank you to our sponsors again. Once again, to our incredible panels, thank you, and panelists and moderators, we appreciate it. And now I hand it off to Sandra from ACHE.
Great. Thank you so much. On behalf of ACHE, I just want to thank our chapter leaders that planned today's session, our moderator, the panelists, and all of you for your participation. Please do complete the evaluation that I have put the link in the chat for all of you. That will be open for 1 week. You can also access it by visiting your My ACHE page and selecting My Online Learning from the helpful links section on the right side of the screen. From there, you'll click on Access My Courses and you'll be directed to our learning management system where you can complete the evaluation. In this same location, you'll be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of virtual interactive education credit posted to their My ACHE account within 2 weeks of this session in the My Education Credit section. That does conclude our session, which is copyrighted in 2024 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone.